I have the opportunity to explain, like as an appetizer for the upcoming talks, what we have in Diagnostic Toolbox for optic neuropathies. When you think about that, looking on the OCT parameters, we can somehow distinguish between first diagnosis and progression analysis, and there we can again differentiate between the different parameters like RNFL thickness, BMO MRW, posterior pole, also some kind of OCT angiography and structure function analysis. On the other hand, looking on progression analysis, I will somehow show you the possibilities using RNFL analysis and posterior pole using deviation maps. But thinking on that, we first need to know what we actually measure. And there you see a nice image indicating the RNFL bundles. Oh, the person, oh, maybe here. Yeah, the bundles coming from the retinal ganglion cells and then moving to the optic disc, like in this shape. And with this circle around the optic disc, we can just measure the axons and somehow the amount of axons together with the connective tissue that is like in a cross-sectional analysis around the optic disc, and thus being a marker for the amount of axons leaving the eye towards the brain. On the next slide, you see a cross-section, like over here, and there you can see in histology in a normal eye that we have the axons going down to the lamina cuprosa and then leaving the optic discs, forming a small excavation over here, while in comparison to the eye with glaucoma, you see there this sharp edge and the posterior movement of the lamina cuprosa with the NFL and axons somehow missing at this borderline. And when you compare that to what we see in OCT, you see in normal eye comparing to this histological section, there we have all the connective tissue, the retinal nerve fibers and the axons leaving the eye towards the brain in this area. And somehow comparable to what we see in glaucoma is this eye with glaucoma, where you see that we have this posterior movement of the lamina cuprosa, where we have only little accents going out of the eye at the border between Bruch's membrane and the internal limiting membrane his. And you have very close relationship between histology and what we can actually see in OCT. And then moving one step forward, away from the optic disc to the retina and the fovea, comparable to what we saw before, we can differentiate all the different layers in the retina coming from the retinal pigment epithelium, the different structures of the photoreceptors, the outer nuclear, outer plexiformer, inner nuclear, ganglion cell layer leading towards the retinal nerve fiber layer. And comparing that again, we can all name them and we can segment them and differentiate to see what there might be between different optic neuropathies and how we can use this as a marker for diagnosis or for progression analysis in the course of the disease. And using that, we have quite a lot of scans that are going through. And then when we use, for instance, the ganglion cell layer, we have this nice donut around that is, as we have no ganglion cells in the fovea itself, it's around the fovea and then less thin towards the periphery, and we can also use the retinal fiber layer thickness that is very thin in the inner part, but on the upper and lower, we have the thick bundles that actually lead to quite good measurements that can be used for diagnosis as well. But when you look on daily life and what we use, we don't have only OCT, but the most important thing is fundoscopy, where we actually can have quite a lot of information, where we need only very little additional examination to go to the disease or to the phenotype this patient had. But all the other examinations going from perimetry, other functional parameters such as pupillary function or electrophysiology help us to get the correct diagnosis. And in addition, we have all the morphological measurement I was just explaining to you. And the challenge is, if a patient comes to us, to actually differentiate these quite a lot of amount of optic neuropathies. You have several talks in the upcoming 2 hours, somehow making you or training you how to differentiate the diseases coming from glaucoma, like pre-perimetric, or treating glaucoma over its disease curves, then anterior ischemic optic neuropathies, optic neuritis, optic disc drusen. You have a quite talk in the upcoming, and there are quite a lot of different other entities that can lead to optic neuropathy later on and should not be somehow mixed up with other diseases. When we now go to our first case, that's a 45-year-old man. He has no family history of glaucoma. He is mild myopic, has an IOP of 28 and 25, and a slightly thicker central corneal thickness. What do you think if you look at the optic disc? Who thinks this is glaucoma? Who thinks this is normal? Okay, let's have a look. You see the visual field. There might be a slight deviation in the upper part. It might be somehow being in this Bjerrum shape as well. But when we move on to the OCT imaging, you can see in the peripapillar RNFL thickness that you have quite a normal thickness of this layer within the statistical range we have for normal eyes. Comparing to the left eye, it's quite comparable. If we go to the MRW analysis, we see that it's quite thick all over again. And in the ganglion cell layer of the posterior pole analysis, you see the same as well. It's quite normal. So in my case, it's an ocular hypertension subject, and it didn't change over the next years. So it's quite sure not glaucoma, but it's somehow challenging to see this just by looking on the optic disc. Now let's go to the second example. 42-year-old patient, again, no family history of glaucoma, mild myopic, normal IOP, slightly thinner perimetry. You now see the optic disc. Who thinks this is normal? Who thinks this is glaucoma? Okay, let's see what the additional examination shows. So that's the visual field of the patient, and if you look on the optic disc, it looks quite surprising that it's quite a deep visual field defect in the upper part. And if you go further on using morphometric parameters like OCT imaging, you see in the RNFL thickness in the lower part, where you could see here this notching down here, and here as well this notching, corresponding to that thinner RNFL thickness and thinner MRW, and the same for the left eye and even broader in the left eye. And when you then go to the posterior pole analysis, you might think on the right eye you can't see anything. On the left eye you see the donut is somehow eaten up, at least partially. And you can see, like here is in statistical analysis, a deviation from normal. But if you really closely look, you can see on the right eye as well a small deviation, and it's down here. There, it's the RNFL thickness analysis, and you can see that there's actually a statistical deviation as well, indicating there might be an early damage, or at least a damage at all. Keeping that in mind and thinking that we have quite a large visual field defect with almost no change at the optic disc, but in RNFL thickness, you may discuss what is actually a structure-function relationship with that. And that's where the Garve-Heath map and other maps come into the play. If you look again on these picture, you see that it's not really horizontal, but the temporal segments are somehow shifted towards the fovea. And that's the reason, or the reason why that is because we have some function structure correlation that indicates, as here shown by Garve-Meep, that if you have it more temporal shifted, it can better present the central visual field defects, while the more peripheral visual field defects are slightly more towards the nasal part. And we use the same in our data with over 1,500 glaucomatous eyes using the octopus perimetry, and we could somehow show the same. If you have a broad visual field defect, it's more in the superior nasal or inferior nasal part compared to the central visual field defect, where you have the deviation more towards the temporal sectors. When you now think, okay, what shall I take into account to actually make a good diagnosis? There I want to show you a nice analysis that will be discussed in more this afternoon when Simon Koenig gives his talk about artificial intelligence. We did a nice analysis with about 2,500 patients, half normal, half with glaucoma, and analyzed what are the parameters that will lead for actually a glaucoma diagnosis later on using artificial intelligence. And you can see that it's primarily the temporal inferior RNFL measurement, followed by the MRW measurement in this sector, then the temporal superior RNFL and the MRW of the temporal superior sector, which makes clinically sense, but could be somehow repeated or will shown again as we thought before. And it's what's always published a few years ago, showing that if you have a corresponding defect in MRW and the RNFL in one sector, temporal superior or temporal inferior, it's quite likely that it's glaucoma, while if you have other deviations, it might be other optic neuropathies behind. Thinking about the next case, like here, what do you think it is? Let's show the picture to you. We have there the optic disc that is slightly degenerated in the upper part. We have a large visual field defect in lower part. Looking on the RNFL, we have a very, very thin RNFL thickness in the upper part, while the MRW, that's by purpose a scan that is vertical, that you can see that is actually just normal appearing tissue, quite a normal measurement, while you see here the donuts still somehow eaten up. So that's, do you have any idea what? Yeah, exactly. It's a pale optic disc after an anterior ischemic optic neuropathy, and that's quite typical because there you have normal connective tissue that is still somehow survived or scarred in this area, while the axons are gone, and this looks like MRW is normal while the RNFL is not. Let's move one step forward that you have some introduction for progression analysis for the upcoming talks as well. A young patient, 30-year-old, no family history of glaucoma, mild myopia, pressure slightly at the upper end, and normal pachymetry, a free visual field defect. You may discuss whether it's glaucoma or not at all, but we have additional examinations, and you see in the RNFL there is slightly thinner RNFL and slightly thinner MRW, while in the left eye it looks normal, and you see here a bundle defect, but the left eye still looks normal. This patient came to our hospital and we started treatment. First with prostaglandins, and then we moved and increased the treatment as good as it was able to tolerate, till we finally end up to be forced to somehow do a trap at this time point. And I will show you why we were, at least in our opinion, were forced to actually move in this young patient to this aggressive treatment. Looking on the MRW analysis, you actually can't see any much change over time. You may wonder what is that, and that's just that it increases after a trap, and that's quite well reported in literature. And when you look on the RNFL global analysis, you really can't see much a change. But if you then go to the temporal superior quadrant, it still looks stable. and the temporal inferior, you see how it moved down. And that's the reason why we decided to do a trap over here. So if you do any analysis on your patients, have in mind to look on the segments as well. And one step further, always have a look on the raw images, whether you can see this deviation from baseline to follow up in the raw image, not to just rely on any measurement artifact. And as a last step, you have the chance of using deviation maps, like the ganglion cell layer over here, just the left eye, where you actually can't see much change. But if you use the NFL thickness analysis of the posterior pole, you can nicely see the widening of the bundle defect over these 5 to 6 years. I hope I gave you a small introduction to what the diagnostic tools of OCT and also perimetry can be, and that you have the ground information for the upcoming talks. Thank you.